I suppose that what I'd like you to leave today with is just a few key pieces of information. One, alcohol is the most common form of brain injury in the age group 35 to 55. Under 35 it's head injury, over 55 it becomes stroke. But it's actually the most common form of brain injury in 35 to 55. Practically nobody knows that. Two, 1 in 8 Australians drinks alcohol at a level which is likely to cause a brain injury in the long term. So whether you know it or not, a substantial proportion of your clients, people you see, are likely to actually be drinking alcohol at a level that might cause a brain injury. 3, it sneaks up on you. Doesn't happen overnight unless you have an acute illness like Wernicke's encephalopathy. And so people don't see it coming. And that includes the person themselves and the others around them, family, friends, workmates. So by the time people actually think there might be a problem with their thinking skills and stuff, it's usually too late. They usually already have a problem. And I'll show you some stats about that. The next one is, I guess, that there are safe levels of drinking. So it isn't a drug where total abstinence is the recommendation. It's not, because there are actually safe levels of alcohol consumption. So they're some of the, I suppose, basic things I'd like you to take home. If you can leave home, or go home with those in your mind, I think, and that awareness, that'll improve your ability to identify it, potentially manage it when it turns up in your workplace, because it turns up all the time. And there are certain workplaces where it turns up more often than others. So if you happen to be a nurse who works in the forensic system, if you happen to work in jail, for example, anybody have any idea about the prevalence of brain injury in prisoners? Yeah, 40%. We did a research project back in 2008 through Corrections Victoria, and gave serial neuropsychological assessments to prisoners being sent to jail after sentencing. And it's the first study of its kind in the world, because people had estimated it on self-report, but no one had actually ever assessed it. And the assessment levels were 40%. And the research actually won an international award for doing this. So there are groups like prisoners where it's extremely high. And the most common cause of brain injury in prisoners is drug and alcohol. Now, we are focusing on alcohol today because it is the most common drug. And you've heard a bit of this preamble stuff already, that all neurotoxic substances, all drugs, alcohol, have an acute intoxicating effect and a withdrawal. Even if you're not addicted or you're not dependent, if we go out and have a heavy night, we're not going to feel too good the next day as our bodies cope with the substance leaving our body. They all have the potential to cause damage to our thinking skills in our brain. Certainly in the acute term, like if you go and overdose on something, if you go and drink 2 bowls of scotch and you're not a regular drinker, if you're lucky you'll just pass out. If you're unlucky you'll actually kill yourself by going into respiratory arrest. But most of them also have a long-term cognitive profile. Part of the problem when we're looking at this in research terms is that there is not a direct correlation between substance use, including alcohol, and brain injury, because there are safe levels of function. And so research in the past has made the mistake of saying, oh, there must be a direct correlation. You know, you have 1 drink, you get so much percentage, you have 10 drinks, you get so much percentage. It doesn't work that way. With alcohol, you'll only be susceptible to a brain injury if you've drunk enough, in other words, you reach that threshold, and you've drunk it for long enough, so you reach the time threshold. And in males, those thresholds are 8 standard drinks a day for at least 10 years. There is certainly a grey area, so 4 to 8 standard drinks per day for males is a grey area. And because I'm not talking about other physical or health issues, I'm talking about brain injury. Unfortunately for females, it's half that. So for females, it's only 4 standard drinks a day for 10 years or more, puts you at risk of getting a brain injury. It's not a lot of alcohol. 4 standard drinks, half a bottle of wine, 3 stubbies. It's not a lot of alcohol. This is why 1 in 8 people drink at a level which might cause themselves brain injury in the long term. The other interesting thing about brain injury and substance use is that the brain injury syndrome of cognitive impairment is often wider or more than the acute syndrome. And one of the classic examples of this, for example, is in benzodiazepine abuse. And that's my other area of interest apart from alcohol. We've done quite a bit of research on benzos. So the short-term effects are all related to speed of processing and attention and memory. But one of the long-term brain injury effects of benzos is a visuospatial disorder, which you do not see in the acute setting. So this is one of the ways when we're doing assessments on people who are still using, whatever that using is, to determine whether we're just seeing an acute toxic effect on functioning or actually seeing potentially some evidence of long-term brain injury. Because unfortunately people still turn up intoxicated when I do assessments. There are neuropsychologists who say I won't assess somebody when they turn up intoxicated because I don't know what's going on. If they're high on something, I say, well, what if this is how they are every day? You can still do an assessment if someone blows 0.35 on the breathalyzer. It just means that you're saying this is how they function on a day-to-day basis like this. If they stop drinking, they may improve, but this is how they function. So, yesterday's client turned up having drunk a third of a cup of vodka that morning, and he drinks a third of a bottle a day. So he'd had his morning share, had a couple of bongs before he came in for an assessment. Funnily enough, he didn't do very well on assessment. And he complains about having a memory problem. And I think, well, are you surprised? Are you surprised you've got a memory problem? Anyhow, he was 44. And that's another issue which we'll come to about why don't we pick people up. Because it does take 10, 15 years, generally, for alcohol to cause a brain injury, you don't see people until they're mid-30s, late 30s, generally showing these signs. And if you try to explain to people, well, this could be your alcohol doing that, then of course they say, well, I've drunk like this for years. It can't be the alcohol, it must be something else. So this is often a problem when people turn up in the system, and they usually turn up because they're sick, and I'll show you some stats about that too. I should say that one of my other jobs, I've got lots of hats now. I actually no longer work at La Tribune. I took a very nice redundancy package as part of their restructure, having been there for 17 years. So I now do full-time private practice. And now I've distracted myself and forgot what I was going to tell you. What was I saying? Other jobs, that's right. So as well as doing our bias, I work at TAC, I do medico-legal work in prisons. I go out to prisons quite regularly and do assessments. I suppose that one of the things that comes across in this area is that even when you think blind Freddie should be able to tell this person has a problem, people often don't. And I'll get lawyers refer clients to me, say, I don't think they're quite right. There's just something doesn't seem to be going on in there. And you assess them, they're seriously, seriously impaired. And you wonder, how did you get this far without someone raising this question? And it's a common problem with alcohol. How do they get this far before someone starts questioning the problem? So if you can take that away with you and say, I really need to be thinking about this all the time when I'm working with clients. And it never fails to flabbergast me as to how many people don't ask clients about their drug and alcohol use. They just never ask. I see files and reports where it's never been mentioned, and people often say, no one's ever asked me that before. And you sort of think, well, why not? It's something everybody should ask. Sort of said that already. The other issue I was going to say, that's right, is that our brains also become more susceptible to things over the age of 40. Whilst they still develop up to age 25, and particularly the frontal lobes, you have a period of where I suppose you're on a plateau. And then once you get to 40, unfortunately, the old neurons start to drop out. And so if you are using substances, you sort of hit this double bang. I've been drinking long enough now, and now my brain's not as able to cope with this as much as it used to be. And you can see people go downhill quite quickly. We won't go through that because it's already been covered, abuse, diagnosis. So alcohol affects us in many ways. It affects our nervous system. It's got a toxic effect. It affects blood flow. It affects, it causes dehydration. It affects your uptake of thiamine. which is an important point because a lot of people with alcohol problems don't eat well, so they get nutritional deficits. And the most common nutritional deficit is thiamine deficiency, and which leads to Wernicke's encephalopathy and Korsakoff psychosis. So even if you have clients who are being given thiamine because they're a known alcoholic, if they're still drinking, it actually reduces the positive effect of taking thiamine. So it's important to keep that in mind. Alcohol brain injury comes in two forms. You have the memory impairment, and then you have the dysexecutive syndrome. We're talking about thinking, emotion, behaviour, and physical movement. The physical movement is related to the thiamine deficiency, and we'll talk about ataxia and neuropathy. But the memory impairment physical movement syndrome is quite distinct from the dysexecutive syndrome. People often call the dysexecutive syndrome dementia. So if you look at a DSM and criteria for what is alcoholic dementia, it's memory impairment plus problems with language or executive skills, etc. I actually don't like the term alcoholic dementia. It's a very medical term. The reason I don't like the term alcoholic dementia, there's several reasons actually. One, if I ask the man in the street, what is someone with dementia, what do they look like? Everybody thinks about Alzheimer's disease. Two, if you stop drinking, you won't get worse, you could in fact get better. Three, it does not affect all your cognitive functions. And one of the reasons we're poor at picking up early alcohol-related brain injury is that the person's still very good at many things they know. And so I just personally don't like this term dementia because of the connotations of what people attach to the word dementia. But it is still commonly used. It's very popular with the Americans. It's not so popular with the Europeans. And Americans and Europeans rarely agree on any medical issue. This is one that they don't. It's also not the same as having an intellectual disability. So alcohol brain injury occurs generally on a brain that's been developed, so you already have a lot of skills, very different to someone with an ID who might have a general lowering of skills. So the Wernicke-Korsakoff syndrome, go through this very quickly. So it's thiamine deficiency. It affects various aspects of the brain, but the most commonly affected areas are the mammillary bodies and the thalamus. So if you do neuropathological examinations, you'll see microhemorrhages in the thalamus and mammillary bodies. Both of these are extremely important for memory. And so that is why someone who has an acute Wernicke's encephalopathy or then recovers but is left with memory impairment, this is why. The interesting thing though is that there is a clear connection between alcoholism and thiamine deficiency and the permanency of memory impairment. Because people who get Wernicke's encephalopathy but aren't drinkers usually recover really well. So this is people, for example, who go on starvation diets, get lost in the bush. They did huge studies on all the prisoners of war from Changi, and I'm sure you've seen their photos where they're skeletal, and they were all thiamine deficient, yet not one of them had Korsakoff psychosis. So there's something about alcohol and thiamine deficiency which interact with each other to cause this permanent condition called Korsakoff psychosis. So it's not just a simple issue of they're thiamine deficient. So the Wernicke-Korsakoff ataxia, so wide-based gait is the general ataxic gait for the alcoholic. The neuropathy, so they walk with a high-stepping gait because their feet, fingers are burning or numb, and you put the two together, you get someone who walks like a thunderbird, you know. I'm sure, have you seen that, the people walking like this? They've got alcohol brain damage. If they have ataxia and neuropathy, they have alcohol-related brain damage. The only question is, how bad is it? You rarely see all these signs these days, and this is why Wernicke's encephalopathy is underdiagnosed, because the most common symptom of Wernicke's is confusion. So someone who turns up with confusion at the emergency department, yes, they might be hypoglycemic, they might be having a diabetic attack, they may also actually be having a thiamine deficiency attack. And it resulted in the ambulance operators changing their protocol some years ago, because the general protocol for an undiagnosed coma or confusional state was to give somebody glucose. And that's the worst thing you can do if someone's actually thiamine deficient, because they can't metabolise the glucose and they become hyperglycemic and die. So the protocols changed some years ago that in undiagnosed comas and things, they would give both thiamine and glucose just in case. And you may or may not know that in the mid-1990s, they started fortifying flour with thiamine. Did you know that? No? The government decided they needed to do something about all the people who were turning up with Korsakoff psychosis, so they fortified flour, and the prevalence of Wernicke's encephalopathy went down greatly, because most people who are alcoholic and aren't eating well tend to eat junk food, so pies and stuff, and so they actually get some benefit out of that. So there's just a couple of brains to show you a non-alcoholic's brain with a reasonably sized third ventricle, and an alcoholic's brain with a clearly atrophied outside of the brain, as well as a significantly dilated third ventricle. So your brain shrinks, basically. And the reason your brain shrinks is for two reasons. One, a bit of dehydration, but the other reason is that what alcohol does to your brain is it actually burns your white matter. It literally burns away your white matter. And so eventually, when you burn enough of it, it dies, the neurons die, and then the brain starts to shrink because the white matter is not as robust as it used to be. Now, I put this table up because this is the way that people generally present to places like our bias. They've been referred because of suspected alcohol-related brain injury. This is the first time they've ever been referred for such an assessment. And yet, and young and old is below and above 40, and yet nearly half of the people above the age of 40 have a cerebellar ataxia and a peripheral neuropathy. It's the first time they're being assessed. And even 1 in 10 have under 40 have a neuropathy, and 1 in 7 have an ataxia. So when you see these people, you say, again, how did you get to this state without anybody actually asking or doing anything about it? And usually the reason they get to this state is because they're now really sick. So most of the referrals for these assessments come through doctors, emergency departments. It's 90% of them are actually medically based. And I'll show you the stats of how their lives have actually already fallen apart before they come for our assessments. And as you can see, there's low rates of formal diagnosis of Korsakoff's, Wernicke's or dementia. Some of the interesting symptoms of alcohol, and why do we miss it, is that because it gets misdiagnosed as other things. So people assume, for example, that you can only have seizures when you're withdrawing. Not true. You can have seizures when you're intoxicated. And so there's quite a few people with alcohol-related seizures who get misdiagnosed as having epilepsy because they weren't going through withdrawal when they had the seizure. Simple solution is to actually stop drinking and they won't have seizures. You add medication on top of it, it creates a new problem. The other issue is that people often get misdiagnosed as having psychotic disorders because there is alcoholic hallucinosis. And alcoholic hallucinosis generally takes the form of conspiratorial auditory hallucinations. So most people with alcoholic hallucinosis are hearing somebody in the room next door making plans to do something to them, things like that. They generally don't get visual, they get auditory. And so we will often see people who've been diagnosed with schizophrenia, and you're trying to look for the evidence of all this, and you say, don't know if that's true. I think it might just simply be a case of alcoholic hallucinosis. So people often go to all sorts of extremes to find a medical reason that's not alcohol before eventually the penny drops. And this, I guess, was rammed home to me when I was a very young neuropsychologist in Sydney, and a client was referred for an assessment. It was an interesting way they came around, because this client woke up they lived in a 2-bedroom unit on the second floor. They woke up one morning on the entrance of their block of apartments, and on the sort of the covering the roof, having knotted together sheets and climbing down during the night. And they went to see their doctor, who thought they might have been having sleepwalking or having a seizure disorder. Sent them off to a neurologist, who kudos to the neurologist, to decide if this person actually might have an alcohol problem, send him off for an assessment. Well, and blind Freddie could tell this bloke had an alcohol problem because you walked in the door, you could smell him. And he was a white wine drinker, and white wine drinkers have a really particular odour to them. I can pick them from a mile off if they're intoxicated. So if you're going to be an alcoholic, try not to choose white wine, try something else, because people can tell. He was a policy advisor to a state government minister and swore black and blue that he drank no more than half a bottle of wine a day. And he blew 0.32 on the breathalyzer, and he was walking and talking quite coherently. So there were two morals to that story. There's a third one I'll get to. But the two morals are, you can't believe what people tell you. If they're an alcoholic, they seriously tell you how much they're drinking. The general rule of thumb is you generally double it. In the extreme cases, you might even triple it. And people will look for another reason for why they're unwell other than their alcohol. The third moral to that story was in my young days. I said to this bloke, can't test you like this, go away, don't drink for a day and come back. Funnily enough, he did. He actually didn't drink for a day and came back, blew 0.11 on the breathalyzer and then proceeded to have a withdrawal seizure on my floor. So I learned very, very early, don't ever do that to a client who's clearly addicted and intolerant. You don't tell them to go away and come back and don't drink, because this is what you're going to do.